So I'm going to talk to you today a little bit about ARFID, which is Avoidant Restrictive Food Intake Disorder. Hopefully the presentation just gives a bit of an overview of what ARFID is, having a little bit of an understanding about how we manage ARFID, and then thinking a little bit about ARFID in education settings as well. So just a little bit about me. So my name's Emily. I am a specialist mental health practitioner and I'm a CBT therapist, and I'm the ARFID lead on the eating disorder team at Alder Hey Hospital, which is we're known as Eddie's. A little bit about the team. So we are a community-based service, and we are commissioned to look after young people across Liverpool, Sefton, Southport and Formby. We were established in 2015 following some new national funding, and we look after young people up to the age of 18. We are quite a big MDT. We have psychologists, we have psychiatry, we have paediatrics, mental health nurses, family therapists, we have dietetics, OT, speech and language, assistant psychologists, support workers. So we've got, you know, a whole range of different professionals on the team with different skill sets, which is just really helpful for looking after our young people. Just a little bit of context as to how and why we've developed an ARFID pathway. So in 2019, there was an additional £11 million funding for children and young people in community eating disorder services. And that was with the expectation that ARFID pathways are developed within the community eating disorder teams. There's been a long-standing gap in services for children and young people with ARFID, and for a long time, young people were just unable to get a diagnosis and it wasn't particularly recognised. You've probably heard over the years things being referred to as, you know, picky eating, they've got a bit of an eating phobia, it's just really extreme fussiness, but actually it's now recognised as a diagnosis, and it's ARFID, and there are now community teams that can support young people when they do have that diagnosis. The pathway development was delayed within our service because of the increase in referrals and presentations we got for young people with the likes of anorexia and bulimia during COVID. But we've now levelled off the rise in those referrals. We've expanded the service more with additional clinicians, and now we've been able to develop the ARFID pathway. So we're very lucky in that sense, that we have a service to offer the young people across Liverpool and Sefton. Before we start, I just wanted to kind of get a bit of a sense from people about what people's experiences are of ARFID. So has anybody worked with children and young people before that have got a diagnosis? Has anyone got any thoughts that they wanted to share before they started? Do people have kind of professional experience of ARFID, or, you know, there might be people here that have got lots of experience and there might be people that have never worked with it before. So I just wanted to kind of gauge really where people are at, if people feel comfortable with kind of shouting out and letting me know.
I've got a child. I'm Anne from Sutton Heath Primary School. I've got one child with ARFID diagnosed that was private, but I think parents are struggling to know what to do or how to support, and we'd like to be able to do the same equally with them.
Yeah. Okay. Did you say Stockton Heath you were from?
Yes, I did. Yes.
Yeah. Okay.
Emily, Becky Emery's got her hand up as well.
Sorry,
Becky?
I can't see anybody's faces, so please just...
Fine, you're absolutely fine. I was just going to say that I've come from community services, and there's a real cautious approach to ARFID because there isn't a specialist service directly in the borough, and people are, you know, like the OTs and things are very reluctant to get involved. So there is a gap sort of within Warrington, and it's quite difficult sometimes trying to explain to parents why some areas have provision and some areas don't.
Yeah, it is. That's a real challenge, and it's a challenge we find as professionals as well, really, because our neighbouring services don't all offer a pathway, and sometimes young people can be in the same school, and a young person have a diagnosis and another young person not be able to access one or get the same treatment. It does become quite difficult in terms of for families to manage, for us to try and explain that to families as well, and to young people. Has anybody else got any experience?
If you prefer to put it in the chat, I can keep an eye on the chat.
Okay. So I'm just
Okay,
going to
Emily.
Sorry,
Yeah, sorry, there's just somebody who's put, we have 2 children diagnosed with ARFID and a couple of questionable children who opt for restricted food.
Okay. And is it a question over those children because you're in an area where it's been difficult for them to access a diagnosis? Or is it a question just in terms of families haven't pursued a diagnosis, they're not maybe interested in exploring that? Or what's the question mark?
Okay, so this is Joanne Atherton from Bluebell Park. So I don't know if Joanne can. Yeah, Joanne, go ahead. You're on mute, Joanne, sorry.
Hi, sorry, everybody had to teach me how to unmute. Yeah, we've got 2 children in our Eastcroft site who have got a diagnosis of ARFID, but both of their parents struggle to find support because it's a postcode bit, really, I think, because depending on their postcode, there's not actually some support for them. So even though they've got the diagnosis, it's not there as support. But we do have other children who have got self-restricted food intake, so they'll only eat particular foods.
Yeah, we'll have a little bit of a think about that as well, Joanne, because partway through we have a little think about what might be rule-based eating in the context of ASD, for example. We'll have a bit of a think about how anxiety can impact children's eating, and then we'll also think about which bits of it then fall into ARFID as well. So we'll pick up on some of that as we go through. Thank you, that's really helpful.
Thank you.
So thinking about what ARFID is then, so ARFID, if we look at kind of the first bit where there's 3 sections here, so there's either an apparent lack of interest in eating, there's food avoidance based on sensory characteristics of food, so texture, taste, smell, appearance, things like that, and there's concern about aversive consequences of eating or a fear. That one of them or multiple of them needs to be coupled up with the points on the other side. So what we would then look at is, okay, if a child's got an apparent lack of interest in eating, what else goes alongside that to make it ARFID? So we would be having a look at whether there was significant weight loss or failure to gain weight if it's required, or faltering growth. We'd look at whether there was any significant nutritional deficiencies. We'd look at whether there was any dependence on oral or enteral feeding. So what I mean by that is whether they're dependent on supplement drinks to get their nutrition, or whether they have an NG tube in place, or they have a PEG to support their feeding and their nutrition. And number 4, whether there's a marked interference with psychosocial functioning. So just to think a little bit about them in more detail. So when we're looking at some of these things, these are the things that we're considering. So when we're saying a significant psychosocial impact, we're not talking about it's really difficult for the family to have a meal out and go out for tea on a Friday night. What we're talking about is the young person's got very poor school attendance or is a school refusal because it's so overwhelming in terms of the smells in the canteen at school. They're just not able to kind of leave the house. They're not able to go out. It can be really, really difficult. The anxiety of knowing that they're going to have to sit in a canteen at lunchtime is so overwhelming. They're not getting there in the first place. Whether there's difficulties leaving the house and kind of functioning day to day. If the family are unable to go out for family days out. So for example, a family might say to us, John has 2 siblings as well, and we've not been able to go out and take them anywhere either. We've not been able to do a family day out because it's too unpredictable where we go. We don't know if there's going to be something there that we're able to buy him that he's willing to eat or that he's able to eat, coupled up with the busyness of it and maybe the smells of where we're going. If people are eating near him, it's just too unmanageable. So that's not happening anymore. You know, for us, they're the things that we would be looking at. Actually, okay, this is having quite a significant impact. Some of the other things we look at are things like if parents had to take time off work or take time out of work or ended up with quite a very flexible working pattern to support eating in school or to take supplement drinks into school, things like that. Something that's really kind of out of the remit of what kind of, you know, usual life would look like. The things around the dependence on enteral or oral feeding. So does the young person have supplement drinks prescribed and are they able to tolerate them? So some of our thinking around this is some young people have supplement drinks prescribed and it's in addition to an oral intake, but it's just to kind of top them up energy wise, and that's working for them okay. Other young people might be not taking anything orally in terms of solid food and only relying on supplement drinks, which kind of changes the risk and changes the approach slightly. We would think about the risks if a child or a young person was not taking the supplement drinks. So sometimes we have children who can't tolerate drinking the supplement drinks either because of the taste, the smell, the texture of those. That becomes unmanageable, so they're not managing to take the supplement drinks. And we would think about whether they already have an NG tube or a PEG in place. And if they don't, have an NG tube in place, how's their eating looking at the moment, and is there enough time to make enough of a meaningful shift in terms of keeping them well at the same time to avoid those things needing to happen. This can be quite tricky when we're thinking about the diagnostic criteria, because you can have a young person who technically would meet the diagnostic criteria for ARFID because they are taking supplement drinks. However, because they're taking the supplement drinks and they're willing to take the supplement drinks, they could be managing really well. So they're not faltering growth, they're not losing weight, they're managing to get back into school. The supplement drinks really works for them as a family, and family have found kind of a routine around them. So, you know, in those instances, you know, a young person could have the diagnosis but not necessarily require much shift or much intervention from that. You know, on the other hand, you might have a young person who's not willing or not able to take the supplement drinks, is just completely unable to tolerate them. And then we need to do some thinking about, okay, they meet the diagnosis, but what does treatment for this child look like in terms of what's their physical health risk at the moment? What kind of timeframes do we have to make a shift for this young person in terms of increasing their oral intake? The significant nutritional deficiency. So we would be looking if the child or young person has significant nutritional deficiencies that require treatment. Now, this links with the bottom point that I've made, that some insufficiencies can be expected. So I'm pretty sure if I checked the vitamin D levels of most people in this country, they wouldn't be optimal. And it wouldn't do any of us any harm to be on a vitamin D supplement. Things like vitamin D would not be enough to kind of tip it into the criteria of a significant nutritional deficiency. What we're looking at is that a young person is kind of missing whole food groups. They've got, you know, really minimal calcium in the diet, or they're taking no protein, they're not managing to get any protein in, or things like their vitamins and minerals across the board is really lacking. That would suggest they're at risk of the nutritional deficiencies that would kind of span far beyond what we would usually expect. Things like, I know there was a question about PICA. Now, our service doesn't treat young people with PICA, and that's managed by community paediatrics within our service. However, symptoms of PICA can develop when a child's got low iron. It's really common actually for a child when they've got low iron to start eating inedible objects. or attempting to eat inedible objects. So we've, I can definitely think of young people I've worked with, and actually when we've corrected their iron levels, that behaviour isn't apparent anymore. They're no longer engaging in that behaviour. They're no longer kind of displaying symptoms consistent with pica. We'd also think about if the child or young person was taking a multivitamin consistently. So we would check with parents about whether they were managing to take something, and that can just be kind of an over-the-counter multivitamin, but they're things that we consider at the point of assessment as well. And then when we're looking at weight and growth, we think about whether there's been a significant loss of weight. We think about whether there's been a failure to gain weight, if that's what's required, or whether there's faltering growth. So the child's no longer climbing their growth centiles and it's just kind of plateaued at a point where they should be still climbing the centiles and they should be still developing. Does that all make sense? Is there any questions or comments about?
Joanne, is that your hand from before, from Bluebell Park?
Yeah, sorry, it is.
Oh, it's all right, don't worry. Don't worry, I just didn't want to miss anything. It's okay.
Thank you.
Is that okay for everyone? I'm sorry, I can't see anyone, so I'm gonna go on, but if anyone needs me to go back, just let me know. So what ARFID is not. So ARFID is not problems with weight that are related to body and shape concerns. It's not feeding problems that are related to not having enough food in the house, financial difficulties, circumstance, or religion that has specific rules around food. And it's not related to any medical or psychiatric condition that might lead to reduced food intake. So just to think a little bit more around them. ARFID isn't associated. So if you've got somebody who might have they might have a really limited intake and might have always had a very rigid diet, but they might have developed anorexia, for example, and they do have body and shape concerns, that wouldn't meet an ARFID diagnosis as well, because of how their eating was previously. They would need to be treated for anorexia if they had the body and shape concerns and weight related concerns. We would not diagnose ARFID for kind of point number 2 if there just wasn't the access to food, because it's not that the child's not able to eat those foods, it's just that those things haven't been available for that young person to have and to try and to be exposed to on a regular basis. So they're the bits that would need managing to see how the child got on first before any diagnosis would be considered. And the bottom one, to have a diagnosis of ARFID, we need to be sure that it's not best explained by any other physical or mental health condition. So it can't be, for example, like depression, that might give you a reduced food intake and you might lose weight because of it. We wouldn't be diagnosing at the same time as that. We often get lots of referrals for young people who maybe also have like learning disabilities maybe, or we've had a few recently who I've got some kind of genetic conditions as well that we've not necessarily understood well, and we've had to link with our community paediatric colleagues to say, actually, is this level of restriction what you would usually see with a child with that genetic condition, or is this outside the remit of what you would usually see in the context of the symptoms that go along with that diagnosis? And then that would help us determine whether actually their eating at the moment is best explained by this genetic diagnosis or whatever their other diagnosis is, versus actually it's not, it's outside of the normal reams of that. This is ARFID instead. Does that make sense? Are there any questions about that or any thoughts? No? Okay. Who can have ARFID? So anyone can have ARFID, any age. And people with ARFID can be any weight. ARFID can be long-term, or it can come on very suddenly, and it can be a very acute onset. and it can very often co-occur with autism, ADHD, or some other learning difficulties. Now, thinking a little bit about point number 3, so ARFID can be long-term or come on suddenly. This is a, as a rule of thumb, if I was thinking about the young people that are in the service, most of our younger referrals are young people that meet the criteria through the subgroup of lack of interest or sensory-based aversions, because they become very apparent very early on in somebody's development. So even at the point of weaning, or they might have weaned really successfully and then it started to become really difficult. So then we might see our 4, 5, 6-year-olds in clinic and it be from that kind of subcategory. The more acute onset of ARFID often occurs when there's been a traumatic incident. So, for example, there might have been a choking episode, and as a result of that, somebody's developed ARFID because there's a fear of an adverse consequence. So there's a fear that they're going to choke again if they eat a solid food, or there's a fear that they're going to vomit if they eat that food. And often, not all the time, that can be for younger children as well, but they might be our kind of 15, 16, 17-year-olds that we see that have actually managed well with their intake up until that point, but something really difficult has happened and they've developed ARFID because of the fear of the consequence. Does that make sense? Does that feel okay? So if we have a little look at this then, so this is a spectrum of eating difficulties. Now, most children go through phases of refusing some things to eat, being a little bit fussy. There might be some mealtime disruption at times. Last week they might have liked turkey dinosaurs and this week they've decided they don't like turkey dinosaurs anymore. Some of that's to be expected when we've got young children. But ARFID sits on a spectrum, and this is what can make it so complex and so complicated when we're given a diagnosis, because people can move through this spectrum. And it's also thinking a little bit about what do we expect in terms of normal, and when is it kind of moving to the point of the spectrum that it's no longer considered what we would be saying is normal child development. So if we're thinking about mild disordered eating, this might be kind of dislikes of single foods, or refusal of several foods and a bit of mealtime disruption, but usually normal growth. There may be a little bit of micronutrient deficiencies. They might need an over-the-counter vitamin to keep themselves well, but generally doing okay. They've got a little bit from each of the food groups, and it might not be an optimal intake. It might not look exactly like yours or ours, but actually they're eating enough from enough of a range of foods to keep themselves well with the support of a multivitamin. Moderate disordered eating is dislike of food categories. So we're moving on from single identified items and moving on to whole categories and whole groups. So in this, we would be thinking about disliking food categories as a result of things like textures, colours, smells. Usually children that have moderate disordered eating, that's where we will start to see the growth faltering, and we would more likely than not see deficiencies that need treatment. So they might require a treatment dose. So rather than it just be a multivitamin to keep it topped up, they might require a treatment dose of iron, or a treatment dose of calcium, or a treatment dose of vitamin D to get it back up to where it needs to be before they then go on to just a multivitamin to keep it there. And then when we move into severe disordered eating, this is the dislike of most foods. So a lot of the young people we see, and part of our criteria is that they're either missing multiple whole food groups out, or they're having less than 10 food items. So this is a real kind of, in this category, it's a real serious restriction. We would expect to see in this significant weight loss or failure to achieve expected weight gain and faltering growth, significant nutritional deficiencies, we would expect to see some kind of dependence on oral nutritional supplements or tube feeding. And there would be a marked interference with psychosocial functioning at this point. If someone's got severe disordered eating, the bits that we would then be thinking about is diagnosing ARFID and considering whether there's sensory processing disorder in addition to that as well. And they're things that our occupational therapists can help with too. Have people got any thoughts about that spectrum? Does it look familiar to people? Have people seen something like that before? Or, I mean, I suppose people can relate to some of that maybe on a personal level too, in terms of, you know, I think of my little girl, a toddler that I've got at home, and she, you know, part of her normal development is sometimes she will refuse things that she had the week before. She will swap and change. She's finding out what she likes and doesn't like. And I think it's kind of knowing what's normal, and then when it's moving into actually this isn't, we're kind of losing whole groups here. Is there any comments or questions about that spectrum?
There's nothing in the chat, Emily.
Okay.
Okay.
Makes sense to everyone then. Okay, fab.
Thank you.
So thinking a little bit about ARFID and other comorbidities. So if we're thinking about autism first, because I'd say in our service, this is probably one of the most common comorbidities that we see. And sometimes young people come to us without an autism diagnosis, but we explore that with them as well, and sometimes put them on the pathway. So some of the common dietary considerations for children and young people with ASD are their need for routine around meal times. It can include specific seating for them, for the people that they eat with. They might need certain plates or, you know, cutlery to be able to manage that meal time. Very sensitive to smells, sights, sounds at meal times that can all impact on how they manage. Very common to experience some gut upset, so things like constipation or diarrhea or feeling quite bloated. Children might experience food hypersensitivity. So when the body reacts quite badly to certain foods, it's not that there's allergies or anything like, it's not a reaction in that sense, but they're just much more sensitive to the feeling of food in the tummy than what we might be. And just in terms of that, being able to tolerate the feeling of fullness and what that means. They might eat a limited diet, a small number of foods similar in colour and taste. I think, you know, I suppose reflecting on some young people that come into the service, I think this is a really common conversation we have around, you know, the point that it's moving into ARFID and is no longer kind of selective eating in the context of autism, because there's a huge overlap. And as much as ARFID is kind of the, you know, a much more, there's much more of a severe impact on the young person. A lot of kind of the early signs and the early symptoms of ARFID can be very consistent with a typical diet of a child with ASD as well. So if somebody comes into the service very early on with those, and it's been picked up quite quickly, it can sometimes be a bit of a challenge to pick this apart and think about which bits ARFID, which bits autism. If we're thinking about how much of an overlap it has, so some of the current research recognises that autism is seen in those with ARFID at higher rates than the general population. And the range is from 12.5% up until about 33.3%. But I would argue that it's actually probably much higher than that. And I would argue that it's just not recorded and captured as being much higher at the moment because of the challenge with people being able to access ARFID diagnoses at the moment. So I think there's probably lots of young people out there that have both autism and ARFID, but that are yet to receive an ARFID diagnosis because of how difficult it can be in terms of some services offering that intervention and some not. We know young people with autism can experience sensory issues and sensory overload. It can lead to heightened sensitivity when it comes to eating, and it can result in the symptoms and behaviour behaviours associated with ARFID. It adds just an extra layer of complexity, because actually if somebody's got autism or a learning disability as well, it can make it more challenging for the young person to be able to communicate their difficulties, which it doesn't necessarily create a barrier to treatment, but it can make treatment prolonged in terms of it taking much longer for us to be able to kind of identify, treat, have a good understanding, due to the complexities of multiple diagnoses. Does that make sense for everybody? Or have people got any comments about that? Do people see some of that with some of the young people in school around? They might have an autism diagnosis, but not an ARFID one, and
Anybody got any comments?
I just think it does make sense. Thank you.
okay, that's good. So some strategies for supporting regular eating. So things that we ask parents to try, we ask them to communicate with the child's school about their child's difficulties. Now, not every child with ARFID needs the same things. So that's why it's really difficult to kind of say, well, this is what we need schools to do, and it's just A, B, C, because actually what works for one young person might not be particularly successful for somebody else. And a lot of that depends on what subcategory of ARFID that young person has. You know, somebody with lack of interest might need a slightly different approach to somebody who is so hypersensitive and has a sensory based aversion to food. You know, they're managed in slightly different ways. So we always encourage parents to talk to the child's school, tell them about their child's difficulties, and think about whether the child can have some of their preferred foods at school. So I'll talk a little bit about that in a minute when we come to the bit about what we ask of schools. Lots of children will tolerate drinking at school, so we need to optimize that. Now, I know some of the challenge has been in the past. I know there's some rules in schools, isn't there, about only being able to have water or drink at certain times, but for a child who has maybe developed certain rules about I'll eat this food in this location, but I won't eat it here, or I can drink in school because I'm copying, in a way, I'm kind of mimicking and copying my peers, but it's really difficult. We know they've got quite a poor fluid intake at home. We really need to use that and optimize that. So it might be things like incorporating fruit juice, smoothies, hot chocolates, milkshakes into the school day. Sometimes what we would ask though is, so it doesn't cause I suppose a wider need for everybody in the school to suddenly want a milkshake instead of a bottle of water. We ask for parents to buy like a water bottle that's not a see-through one, so you can't actually see the contents inside. So often that can help support the young person to be able to drink something that's a bit more calorific, gives them a bit more energy, and also gives them a little bit more of what they need, i.e. whether it's, you know, a little bit more calcium or things like that, but also doesn't create a situation where the rest of the school year are recognising that they're not bringing the same as everybody else. We ask parents to try and keep a very visual timetable for their young people and plan meals. So sometimes 7-day meal planners at home can be helpful. The child knows what's expected of them and knows when it's expected of them as well. The use of alarms to remind them to eat. This is particularly helpful for our young people who've got a lack of interest. And often our young people with lack of interest, that's where schools can be really important, because actually they're in a situation where they're with peers a lot of the time, and it can really build the curiosity towards food more so than what they would necessarily have at home. Do you know, at home they might be setting an alarm on the phone to remind them to eat if they're a little bit older, but actually in school they might have the school bell, it's snack time, you know, it's a set time that you go into the canteen together, you know, they're sat with peers who are eating things and ordering different things. They'll be watching all of that, so even though they might not have an interest in eating at the time, the hope would be that their curiosity would build enough and that they might just try something, they might look at it. Do you know, we go in with quite a low pressure approach with parents around, there's no expectation that they eat this food initially, but we would ask them to just be in the room while the package is open, for example, get them used to smelling it. Do you know, in clinic I'll do exposure work with young people, And over a number of sessions, we build up to kind of looking at the strawberry, holding the strawberry, licking the strawberry, smelling the strawberry, really getting used to it with all of our senses before there would be any kind of prompt to eat it. So what we ask of the schools, so things like when parents are coming in and letting you know what their child's needs are, to try and accommodate the child's preferred foods, even if it appears to be unbalanced or outside of the remit of what would usually be allowed. Now, I know this can be a challenge, and often, you know, if you were to look in the packed lunches of our young children with ARFID, it wouldn't be what you would usually pack if you were sending your own child off to school or out for the day. But parents have packed that kind of hoping or knowing that that might be the thing that they eat, and that might be the only thing they eat during the entire school day. So there will need to be an element of flexibility to support that. I've had lots of young people who we've talked about sending them in with a packed lunch, so they've got their safe foods, but talking to school about making sure that they can still access the hot dinners if they're curious about something and want to try it, or they want to get something. So it's having that there as an option, but knowing that they can take their safe foods as well, and so they will have something to eat still. We've talked a little bit about the drinking one already. Sometimes we talk to schools and see if they can provide a quiet room for them to eat. Not everybody wants this, and not everybody needs this either. But for our children with sensory-based aversion, the dining hall can be really overwhelming. It's noisy, it's busy. There's there might be a half an hour slot to get lunch, and it can be a lot to try and manage during that time. It can increase anxiety for our children, and when our anxiety is higher, it becomes much more of a challenge to eat anyway. So they're already feeling like they're on the back foot with it. So sometimes having a quiet room for them to eat in, or for them to go in with a friend as well to eat, can just be really helpful in terms of them managing that meal time. Are there any thoughts about some of the things that are on here, or anything people wanted to kind of ask or discuss? I can see a hand up. Is it Debbie?
Yes, Debbie. Yeah.
Hi, Debbie.
Yeah, I am. As a result of pins, where I went into a school and one of the parents was saying that their son would only eat noodles, so she was making them up and putting them in a flask, but then he wouldn't eat them because they tasted different because they was in the flask. And school, she asked school could they make them up for him, and they said no because it's safeguarding. But so I'm just raising what some of the challenges parents are facing from schools, because I mean, I messaged the school and said, well, could you not perhaps get the dinner ladies to make it up 5 minutes before he comes in, and then it's not a safeguarding thing, is it? But I'm just flagging it up basically.
Yeah. What's the safeguarding about somebody making
They're thinking about
noodles?
the hot water. I think that's what they was thinking.
Okay. But I suppose the adults would be making it though, wouldn't they? So the child wouldn't be exposed to the hot water.
Exactly. That's the issue that this parent was facing. So I did flag it up to them, but I don't know what's happened since.
Because I think it is just about that education, isn't it? And I think it's I think the challenge sometimes is, as professionals, we don't always feel like we understand enough about ARFID to then challenge some of these decisions that are made. And I've definitely, in the past, when we first started the pathway, our team felt a little like the same. We were going to have conversations with other professional teams or schools or different places, and we were trying to put things in place, but I think until we feel confident, it's hard to challenge those things. So for me now, I would be going in and challenging that a little bit, and I'd be saying, if this is a safe food for him and he is willing to try it in school, but it needs to be kind of cooked live rather than pre-made in a flask, then that's worth a try. It doesn't need to be a long-term plan, but it is something we should trial. It might be that he still doesn't have it because it's in a different location. Our young people with ARFID, they're so hypersensitive. I've got a young person on my caseload at the moment who's 8, and her old nursery still make a lasagna. And and give to mum every week because it's nursery's lasagna. She's 8. She's
that's
not
what
been in
she eats,
nursery
yeah.
for years, but that's what she likes to eat.
Ah,
You know, and she's found a good nursery who's you. That's not obviously what every child can get. But it is just those rules. You know, I've got young people who will eat a certain thing at dad's, but then they'll go back to mum's. But that's not a mum's food, that's a dad's food, and I'm only
Yeah.
eating it when I'm at dad's house. So I
And
think it's,
sorry.
I think it's about challenging those decisions when we
Yeah.
feel able to challenge them, but then also trying to think with the families a bit about, okay, how could we try and expand his variety to something that
food,
doesn't require
yeah.
cooking either. So things like, how do we manage to get him just have a sandwich, for example? How do we build that up gradually where it doesn't need any cooking either?
I think what was happening as well, because he wouldn't eat anything else. So by obviously come the afternoon, he was starving hungry. So that was creating behaviours and stuff for him. So it's hard, isn't it? Because I suppose from the school's point of view, they'll be thinking, well, everybody will start wanting to eat that, won't they? You know what I mean? So I get it from both sides, really. It's complex.
Yeah. But I think but I also think the challenge is, you know, we're always going to come up against this. You know, if we put this in place for these children, everybody's going to want it. But these children, you know, they're not choosing to eat like this. You know, they're unwell. They have this diagnosis.
Yeah.
And we need to accommodate that. And if other young people that don't have a diagnosis and are just saying, why has he got noodles? I want noodles. You know, that needs to be explained appropriately.
Yeah,
That actually you don't need them. This is what's on offer for you. That's not, you know, you're not having that. We shouldn't shy away from meeting the needs of our young people just because there's a worry
100%,
that everybody's going to want that.
Yeah. Thanks.
Emily, Becky Emery is just pointing out that maybe most of the asks would fall within the realms of reasonable adjustments in schools. I don't know how the schools feel about that, but
I would agree a little bit because and the schools, I'm mindful there's people on the call that are not necessarily within our area as well. So what support they might get might look a little bit different to what support schools in our area might get. But the schools I've worked with in the past have they've been really keen to have regular meetings with us, to work with us, to think about how to get it right, because it has a real, if we're not getting it right from a health and an education point of view, these young people aren't getting into school. It's creating a whole host of ongoing difficulties for them. It's not just that there's a health impact to them not being able to eat, but actually then they're not going to be able to access their education either. So you know, my experience, the schools I've worked with have been really helpful and really accommodating and really happy to welcome suggestions and ideas.
Yeah. We've got a hand up as well, Sarah.
Hi, sorry, I'm just coming from a school's point of view. I think most schools where there's a diagnosis and a child's underweight, you'd be bending over backwards to do it. We do have the same issue though. As soon as a child wants chicken nuggets, another child wants it, but because they've got an ASD diagnosis and food aversions. But we've got 160 children who've got a diagnosis of ASD, and I suppose it's the confidence of the school to be able to say, actually, they're underweight. It's a different level of food aversions, and being able, because we wouldn't be able to do a la carte for them 160 children.
No.
But obviously, where parents have tried noodles, that's not working in a container. Parents have tried and that hasn't worked. So I think in cases like that, schools would do the best to. But it's getting that balance right of understanding, well, actually, we've probably got 160. We wouldn't be able to do that for 160 children. It's like a military operation in our school at lunchtime.
But you know what? In a way, you don't need to do it for all those children because that's not their need. So, okay, they have autism. Yeah, okay, they have autism and your preference might be a nugget, but it's a preference. It's not a need. And they're very different. And it's, like you say, I think it's building our confidence to say, actually, you know, okay, you prefer chicken nuggets. I'm sure you'll be having them for your tea tonight. You know, that's absolutely fine that you want your chicken nuggets, but in school, that's not what we offer you. And we're not going to start offering you that. Versus you've got a child who's got an ARFID diagnosis, is faltering with growth, you know, is having to take supplement drinks, go to regular hospital appointments, just really isn't doing particularly well. That's different. At that point, it's becoming a real medical need. It's for me, some of that's no different to if I was to send, you know, if I was to give a prescription of antibiotics and they had to bring them in school because they had to have a dose in the middle of the day. You know, some of it's what's needed for that child to keep them well and to keep them functioning, to keep them in school.
Yeah, 100%. Sorry, I just thought I'd give that perception.
No,
I think
it's
sometimes
helpful.
ARFID is different to an ASD diagnosis, and I think that education of understanding of what ARFID is and the severity of it
It is very
would
different.
help. Yeah.
It is very different. And I think some of the challenge is, and I suppose I'm thinking more about the schools that are on this call that are kind of outside of our area, that I know your local areas are not currently offering an intervention, because at the moment, if there was a school who was having difficulties meeting the needs of a young person, we'd go in and do a school meeting, we'd really do some thinking together, we'd draw up a joint care plan a little bit. You know, if they already had an EHCP, we'd contribute to that. If they didn't, we might support some of the application process for that. So a lot of it would be driven by kind of joint working between parents who know the child best, schools who know what they can do and what they can work with, and us from a health perspective really understanding how serious ARFID can be. You know, it is very different. It's very different to a child having autism. We know that there's a huge overlap. We know a lot of young people with ARFID have autism as well, which adds complexity. But you can have ARFID without having autism, and you can have autism without having you know, there's going to be lots of just autistic children that don't have ARFID. They're okay. Did I see another hand go up then? Sorry.
Debbie, yeah, Debbie.
Sorry, it's me again.
No, that's okay.
I'm just thinking about, like, the thing is, what if a child has got ARFID and the parents don't even know what ARFID is, for example? Because I know a lot of parents that won't even know what that is.
Yeah.
And they don't have a diagnosis. So to me, that child's not doing it on purpose, even if they've got ASD, to be fair, because it can be sensory issues, like you said before. Then that's like again what that lady was saying before. It's like a reasonable adjustment at the end of the day. And I know they've got all these kids to look after and stuff, but like you said, even with autism, they're not doing it on purpose. It's just that they can't. It just worries me that, and do the GPs know? Because if a parent goes to a GP because the child's not eating, are the doctors aware about ARFID and what where to send these parents to and where to get help for it and stuff?
This comes back to the inconsistency that I mentioned at the beginning. If you've got an area that doesn't diagnose, then you're not going to have that clarification of what that precise need is, whether it is autism, whether it is ARFID or both. And those are the parents, you know, that are struggling, and also the schools, because they haven't got that defined label that enables to differentiate between different level of need for different children. So it is difficult while services are lagging behind in different areas.
I agree, and I think we absolutely recognise the challenge of that, because and like I'd mentioned at the beginning, all the community teams were given, you know, everyone should be developing a pathway. It was identified that there's a gap, and every, just like back in 2015, you know, eating disorders in general previously were managed under CAM services, and it was only in 2015 we got specialist community teams. Now we have the specialist community teams, and now it's part of the remit that we should be offering ARFID. Now, at the moment, some services are, some services aren't, but actually it should be, this is what's happening for every area. It shouldn't be a case of, oh, you're in that area, you get that service, and you're in that area, you don't. I can't speak for the GPs that are not in my area about how much and how confident they are. But actually, the GPs that are within our area do have a pretty good understanding. They were noticing that they're making really appropriate referrals to us, and actually, even if we're declining a referral, we make sure we write back to the GP detailing why, so then they know for next time, and they can hold some of that learning in mind as well. So in terms of the GP knowledge, yeah. The other bit about parents is, parents might not know what ARFID is, but in a way they don't need to know what ARFID is. If they're worried about the child not gaining weight, they're worried about the child only eating between 5 and 10 foods, or the child's just not growing and they're absolutely tiny and, you know, a head shorter than all of the peers, they need to be going to the GP. Don't they? You know, regardless of what they think's the matter or what their understanding is of what diagnoses are out there, that would be flagging it for a parent, you know, as a concern to go and seek some additional support.
Yeah, I get that. And the other thing is, what was I going to say about the sensory issues and stuff? To me, we're all like in society now, it's trying to be pushing about need and not diagnosis.
Yeah.
And it just feels, I think it should be based on need and not diagnosis, really. But anyway, that's just my personal thoughts.
Yeah. It's a challenge though, isn't it? And I think it's a challenge for sometimes people's needs aren't necessarily, they've not been thoroughly assessed because there's not a diagnosis though, or there's not a services involved to assess the need. That, you know, that becomes quite complicated for families, doesn't it? Are people okay if I move on to the next slide? You're going to see my head bobbing around a little bit for a minute. I'm just going to find a plug really quickly to plug my charger in, and then I'll move to the next one. Sorry. One moment. That's better. So, preferred foods. Why are they so important to our young people? They're often calorie dense, so you can eat more without feeling full so quickly. They can be useful for a short period of time to aid weight gain or to increase interest about food again. But the most important thing that our young people tell us is preferred foods tend to be processed foods. In a nutshell, they are the same every time. They are predictable, they don't change, they are the same, there's no surprises. So looking at the picture below is a really good summary of what I mean by that. You know, you open a punnet of blueberries or strawberries, not every single one looks the same, tastes the same. Some of them are squishy, some of them are hard. That's not the same if you open a packet of biscuits. And that's why a lot of our young people have the same preferred safe foods all of the time, because there's just no surprises from them. Thinking about support for schools. So if young people have a diagnosis and are open to us, you can request to meet with the child's case manager, and they'll help you do some thinking about the child's individual needs, the diagnosis or any other comorbidities as well, and how they present for that young person. So what it looks like for them individually, what's achievable and manageable within a school environment. And we'll try and marry up whatever's happening in clinic and whatever we're working on at that particular time. We'll try and make sure the school are aware of that as well, so it can kind of complement each other. And we might explore EHCP applications or review them together if one's already in place. I am really mindful that not everybody is in our area, so this will be different for some of the schools that are on. But I suppose for the schools that are outside of our area, a couple of the main takeaways I'd be saying is there is a very, very big difference between a diet of a child that's quite rigid in the context of autism and the diet of a child who has ARFID. If it's clinically significant and there's health concerns about that child, it's appropriate to be making reasonable adjustments to support them in education. And it's okay to challenge things that we think maybe aren't being done as a reasonable adjustment and having the confidence to do that. And equally, it's okay to say no to other children then that might be asking for some of the same things. You know, if you think about it as a medical intervention, if it was a medication, you wouldn't just be giving it out to the other children because it was asked for. This is no different. You know, some of what they need to be able to keep themselves out of hospital, keep them off an NG tube, keep them in education, is that food. Does that make sense for everybody? So I'm just going to stop sharing this now, just so I can see all your faces again, and we could just maybe have a bit of a time for discussion and questions. After this, I'm going to share these slides. I'll send them back to Helen and she can distribute them. And I've also got some leaflets and resources. They're just like one kind of page A4 ones, but might be really helpful to kind of have to hand or have in your offices just to refer to if at any point you need them as well.
That's fantastic. Thank you, Emily. That was really, really interesting.